let's just assume that Katie, you saw a patient consultation who comes into your office and says, look, I've responded to my frontline chemotherapy. I had a serious, advanced ovarian cancer. And my doctor did this HRD test. Here it is. And she says, but my doctor is not very passionate about recommending that I get PARP maintenance. And I don't have a BRCA mutation. It's an HRD test. Would you say with the same passion that you said for Solo 1 to this patient that, look, this is a no-brainer. You need PARP maintenance. You have a molecular marker, as Tom alluded to. This would be a more than a doubling of the median. So the median HRD positive, excluding BRCA, is a hazard ratio of 0.5, Tom, what you said, going from 8.2 to 19.6 months, more than doubling of the progression-free survival. So what would you tell that patient, Katie? And I'm gonna ask you, Tom Krivak and Sharon Lewin, the same question.
So you asked me about my passion. So I think I do believe that PARP inhibitors are the standard of care with shared patient decision-making for patients who have BRCA-associated cancers. For patients without BRCA-associated cancers, I think they are a standard of care, and there's probably a spectrum in there. This would be on the stronger edge of evidence. This was, the HRD group was one of the analytical subgroups of PRIMA, and it met its endpoint, and I believe that, and we'll get into the debate later. So, I mean, I would strongly counsel this patient regarding the potential benefit of use of niraparib, and then the known risks and benefits, and especially talk about kind of what the gains would be in terms of progression-free survival and what that means without an overall survival endpoint that we won't have for quite a while, although in PRIMA we may get it much earlier than on some of the other studies. And then it would be sort of a shared decision-making between myself and the patient. I think that this is a little bit different, and I do think there's options for bevacizumab, for both, for, some patients just want to do surveillance. I don't know that I'd fall on the sword and beg someone to start, which I do with BRCA associated cancers, but I would strongly recommend this. I think it makes a lot of sense. And these patients are going to recur. I mean, we just have to stop talking about, unfortunately, all these cured high stage patients. They don't exist. Right. I wish they did. I really wish they did, but they don't. And so try to prolong it as long as possible. And I just don't know why you wouldn't.
And I like this idea of shared decision-making, but let's face it, when you give the patient the option of take a pill, it might have some side effects versus, go on vacation. Trust me, you can go on vacation, take a PARP inhibitor too, but they have a tendency to take the easy way out. It's just human nature, right? Because every patient thinks they're cured. You say they don't exist, every patient thinks they're the exception. And I don't know why the doctor thinks they're the exception, but there are many providers that do. So I think
if you present observation as an equivalent option, and it's listed like that in the NCCN, which is mind-boggling, but then they're like, oh, I could do something or not do something. I'm not going to do something. So it's all the counseling. That's
what I'm trying to discuss here. It's the strength of the recommendation in everything 100%. That we do, whether it's a Gardasil vaccine, whether it's a PARP maintenance, it's the strength of the recommendation. Sharon, how strong would you recommend this?
So again, Brad,
HRD in hand, didn't use Bev, HRD in hand, responded to frontline therapy, comes to you and say, Dr. Lewin, you have a great reputation. Do I need maintenance niraparib?
Well, honestly, I really agree with everything that Katie said. Just want to take a quick minute to highlight the importance of the frontline germline testing, which unfortunately not 100% of our women with ovarian cancer are receiving. And there's just data at SGO saying about 60%. So I don't know why it's not quite 100%. But I agree, it really is shared decision making. I mean, I am a big biomarker believer. I know the inherent problems with these subgroup analyses. But I think if the patient does have HRD, of course, if she has a BRCA somatic or germline mutation, I'm going to strongly encourage PARP maintenance.
Tom Krivak, how strong is the recommendation? HRD in hand.
We talk about our financial conflicts what I can say is that I have a biomarker conflict too, in that I believe in HRD and I believe in maintenance. So when I give talks, I automatically say I graduated fellowship in 2002. I thought Markman's trial 12 versus 3 was great. And I've used maintenance therapy ever since. And I think it's important because what's really moved the needle has not been the upfront 6 cycles of whatever we give. It's the maintenance therapy that has moved the needle. So to me, if somebody has an HRD positive tumor, I would strongly recommend maintenance, whether it's single agent niraparib or combination therapy. But I would have to say part of my bias is that when I see folks advanced stage ovarian cancer, I'm going to recommend some form of maintenance therapy. And it's going to be, I don't believe in active surveillance in that group.
Yeah, so people want to know what your conflict of interest is. Trust me, your conflict of interest is not because someone paid you to go to work,
Correct.
Whether it be a drug company or your hospital. Your conflict of interest is that you have seen patients benefit and stay alive and live better with maintenance. So I get that, and in my mind, it's just evidence and evidence based. And so for the audience, I got 4 panelists here and me to not offer with a strong recommendation in BRCA, a maintenance part, and with an HRD molecular signature, you can maybe soften it a little bit. Your head doesn't have to explode, to quote Katie Moore, but my head would explode. If someone says, well, I don't know,